the hardworking, sincere physician, and he is interested in infectious diseases, obesity and diabetes, and is the State Secretary General, TTGDA, and I am a General Secretary, Nizamabad, the API General Secretary, Nizamabad. So, this topic is on dengue fever, and which is a very much crucial point for the physicians, because nowadays we are losing so many patients, not because of the dengue, but because we are not attending them in time. So over to Tirupati.
Thank you, Chairperson, Dr. Rajarao sir, Dr. Baba sir, Dr. Babu Reddy sir, and Dr. Srinivas sir. They will join soon. Narasimha sir, Gandai sir, Srinivas Reddy sir, Raisa Raju sir, so Ravindra Reddy sir, all the seniors and my colleagues. So thank you one and all for making this event grand success. So my topic is today, what's new in dengue fever. So recently in Bhubaneswar, under the able guidance of Bhubaneswar AIMS faculty, we have attended from our state, Dr. Sweta, Dr. Amaravati and me attended that conference, National Training of Trainers regarding dengue fever and chikungunya fever we have attended. So, vectors of dengue, Aedes aegypti, it's a daytime biter. It prefers to breed in domestic and peri-domestic habitats. Almost most of the half of the world will be affected with the dengue fever. High burden states, Telangana and our big brother Andhra Pradesh and our cousins Tamil Nadu, Karnataka, Kerala, all southern states. So we know already dengue fever, 1, 2, 3, 4 types are there and subtypes are there, and fifth variant. So immunopathogens, we have immune deviation, cytokine overproduction, like COVID also cytokine overproduction, and dengue virus induced vasculopathy, coagulopathy, antibody dependent enhancement, and anti-endothelial injury, molecular mimicry. So with this pathological, with the dengue fever, asymptomatic presentation. So no symptoms will be there, and symptomatic 10 to 20%, severe dengue fever 5 to 10%, and death less than 0.2% only. So many patients will come with rapid diagnostic kit. So rapid diagnostic kit is not a diagnostic for dengue fever. It's only probable dengue only. We need to confirm with the ELISA dengue IgM RT-PCR only. So rapid diagnostic kit is not a confirmatory for dengue fever. So less than 5 days illness, we should go for either NS1 ELISA or dengue RT-PCR. If it is positive, so that is confirmed dengue fever. If it is more than 5 days, we need to go for IgM ELISA. So after 5 days, we need to go for IgM ELISA. Less than 5 days, NS1 ELISA or dengue RT-PCR. These are important. So with this case definition, either NS1 or IgM with the rapid diagnostic kit. So if it is clinical presentation is there, it is confirmated dengue only with the dengue shock syndrome. So those terms are now in a phased out stage. So now we have new system. In this we have grade A, grade B and grade C. That is A grade. A2 means with the A1 plus presence of any comorbidities and other risk factors. So this is A1. So with the A1 dengue fever, A1 grade or A2 grade, we need to give OP management. B1 means warning symptoms and signs like recurrent vomiting. These are important, please remember postgraduates. So what are the warning symptoms? Recurrent vomiting, abdominal tenderness, general weakness, and mild stool effusion and ascites. So increased hematocrit with minor bleeds. Hepatomegaly. These are the warning signs and symptoms. If these are there, that is called B1. With warning symptoms, And like it is in the infants, old age, diabetes, hypertension, pregnancy, coronary disease and hemoglobinopathies, immunocompromised and congenital heart disease, okay, malnutrition, cerebral palsy. If these are there, that is B2. So B1, B2, B1 means warning symptoms and signs without risk factors. B2 means with the warning signs. Severe dengue means C1, C2, C3. C1 means severe shock. C2 means significant bleeding. C3 means severe organ involvement like severe metabolic disorder, acidosis or dyslipidemia, other complications. So please remember, this is the new classification. We should not use any dengue fever, dengue hemorrhagic fever, dengue shock syndrome. So those are no more terms. Now mild, moderate, severe. Mild, that is A1, A2. Moderate, B1, B2. Severe dengue, that is C1, C2, C3. This is the new terminology by our NBDCP. So if it is C1, C2, C3 means hospital management is mandatory. So according to this, the grade B, previous one, so we need to give either isonic or crystalloid for 5 to 10 ml per kg body weight. If it is improvement is there, 3 to 5 ml per kg per hour for next 2 to 4 hours. 2 to 3 ml for next 2 to 4 hours, next 1.5 ml per kg per hour, next 2 to 4 hours, then we have to stop. If there is no improvement, we should check hematocrit. If it is more than 45, we should give bolus. So improvement is there, we should give tapering dose. If it is no improvement, if it is more than hematocrit 45, we should go for either blood transfusion or colloid. So we need to give only 2 times only bolus. If it is no improvement, so yes, we need to give only 2 bolus of treatment and the tapering dose. The patient will not improve, we should further workup should be done. So this is for compensated shock. So more or less same, but further improvement will be there. 10 to ml for kg body weight, and even in tapering dose also 5 to 7 ml, then followed by 3 to 5 ml per kg per hour, then 2 to 3 ml per kg per hour up to 2 to 4 hours. Then we have to stop the IV fluids. In decompensated shock, so almost same, but 10 to 20 ml, 10 to ml per kg per hour. So like that, even tapering also 5 to 7 ml per kg per hour, then followed by 3 to 5 ml kg per hour, then 2 to 3, then we have to stop. Very important is previously in 90s or 80s, so in dengue fever, we need to transfuse more IV fluids. With that also, there is a possibility of mortality and morbidity. But we should not under transfuse, or we should don't under transfuse or don't over transfuse. During critical phase, to match the fluid infusion with the rate of the leak, that is important. How much leak is there, how much we need to infuse, that is more important in dengue fever. So in PHC management, OP management, even in the moderate dengue also they can manage. In severe cases, if no improvement, they need to refer to the higher center. So dengue with pregnancy, vomitings of pregnancy, there is a confusion. Is it a hyperemesis gravidarum or is a warning sign? Like in a moderate B1, B2, there is a warning sign. So is it a warning sign? Is it a hyperemesis gravidarum? You need to check. And hemo concentration may be with the hemodilation, there is a confusion. Even cardiovascular changes will be there with the volume overloaded state, tachycardia and low BP shock. So delay in failure to recognize dengue shock, that may be problematic. So in dengue fever, more than 50,000 platelets, we can go for a vaginal delivery. If it is more than 75,000, we can go for cesarean section. If it is more than 70,000, epidural or spinal anesthesia can be done. So this is also important. More than 50,000, sometimes even 80,000-90,000 also. So gynecologists may worry with the 80,000. More than 75,000 of platelets, we can go for cesarean. More than 70,000, epidural, spinal anesthesia. So adverse pregnancy outcome may be severe manifestation, complications of dengue, postpartum hemorrhage and miscarriage. So risk of vertical transmission and increased risk of preterm birth or no birth may be possible. COVID versus dengue, always we have confusion for the last 2.5 years. So previously also I have discussed regarding this topic in previous conference. In dengue fever, main drug of choice is fluids only. But in COVID, we can't transfer that much, it can worsen the oxygenation. So anticoagulation may be useful in COVID, but it can increase the risk of bleeding in dengue. When there is a co-infection, there is a problem. Both COVID positive and dengue fever positive. Corticosteroids, till now in the dengue fever, so corticosteroids may not be indicated. But in the COVID, in the 5th or 6th, 7th day, we can use steroids. But antibiotics, steroids and IV immunoglobulins, no role in dengue fever. So what are the conditions for admission? Significant bleeding from any side, any warning sign, persistent high-grade fever, impending circulatory failure, neurological abnormality, transfusion less than 10,000 platelets only. Even 20,000, 30,000 platelets also, no prophylactic transfusion for dengue fever. Prolonged shock with coagulopathy, abnormal coagulation, thrombocytopenia with hemorrhage. So packet cell transfusion or FFP along with the platelets in severe bleeding and coagulopathy. Overplate fresh transfusion doesn't have any role in managing thrombocytopenia. When there is no SDP or RTP, sometimes they may give a fresh whole blood, but they are not useful in dengue fever. Criteria for discharge of the patient: absence of fever for 24 hours. No respiratory distress, platelet count more than 50,000, good urine output. So urine output is a cheap and a very good indicator for dengue fever. When we are use it under transfusion, over transfusion, so urine output is a good indicator for dengue outcome. So when combined with the dengue fever and viral hepatitis, we need to take care of those, and myocarditis, diabetes. So better avoid metformin and SGLT inhibitors in diabetes. When we are managing severe dengue fever, better insulin and others may be given. So in renal involvement dengue fever, so fluid transfusion may be altered, and CNS involvement. Other co-infections may be possible with the TB, HIV, malaria, chikungunya, enteric fever and scrub typhus. So even the dengue positive, sometimes co-infections may be there. So overall conclusion, the guidelines, proper diagnosis, management. So referral of cases from PSC to IH center. Proper nursing care and fluid management is very crucial. Majority of the patients do not require platelet transfusion. So unnecessarily we should not transfuse. No role of prophylactic platelet transfusion above the 10,000. So high-risk groups need to be monitored very closely. So thank you, one and all. He is my spiritual guru, Kanashantivanam, near Hyderabad. Thank you, one and all. So with hectic schedule, I may not prepare that much, but handle as much as possible. Thank you, chairpersons, for giving me this opportunity.
That polyserositis will be there. So these are the clinical points. Albuminuria will be there, and in the blood hypoalbuminemia will be there. At the same time, you can see in the CBP hematocrit and platelet count. So CBP and CUE will give a lot of input. And most of the times, even at this point, the simple thing is giving Christian syndrome. That is C. Now it is not dengue syndrome, C. And it will be very high. So we have to act at B1 and B2. Okay? Any questions? And don't go by platelet count alone. Because most of the centers where we practice, they don't know how to see the platelet count even. We have to see direct smear. Because most of the centers they will see in the hematology analyzer where the machine will not count the clumps of the platelets. It's a disease where the platelets will be seen in clumps.
Even IC bleed may occur in any point of this platelet count, but there is a risk of definitely IC bleed is there, sir. It may come down and later it may improve, but we should not panic the platelet count. We should look at always hematocrit.
Yes, this is because any hemorrhage, the machine will not count the clumps. This will count individual platelets. That's why always the machine value will be very less. So we have to ask for the direct smear with the pathologist when the pathologist is available. In a remote area when the pathologist is not available, go by coagulopathy, any bleeding manner.
Because when there is serositis means definitely there is a capillary leakage. So according to that leakage we need to transfuse, but in the mild to moderate range only. So we need not to transfuse, over transfuse at that time. It may aggravate. but we need to transfusion even that time also.
No sir,
No, sir.
transfusion and leak there is vasculopathy. So capillary leakage will be there. That we have to replace it. As it told, initially you have to give 3 to 5 ml of bolus, but nobody is giving bolus. That's a problem. We have to give bolus fluid. With the bolus fluid, we have to repeat the hematocrit. Hematocrit should come down. So if hematocrit is coming down, that's a good sign that we are treating dengue fever. Sometimes the investigative modalities may not be available with us, but hematocrit, after giving bolus of fluids, if it is coming down, it's a sign that we are dealing with hemorrhagic fever, with any hemorrhagic fever, with capillary leakage. ml of bolus.
Thank you, Thiru.
Even after giving fluids, if the hematocrit is not coming down, then we have to suspect bleeding elsewhere, obscure places, especially intra-abdominal, where we cannot see. In such places, in such things only, we should consider for blood and blood products. Usually blood and blood products, the role in dengue is very less, but unfortunately it is abused.
Thank you. And one comment I want to make here regarding the epidemiology of dengue. The dengue fevers in Andhra Pradesh, especially in Telangana, it started in Karimnagar in 2000 years time. It spread to the Nizamabad, Hyderabad, everywhere. But one episode, this was very bad. The bad episode.
The heart failure worldwide and the economic burden is around 108 billion, that is in 2012. Heart failure is the number one cause for rehospitalization of any cause whose age of more definition. Heart failure is defined as abnormality of cardiac structure and function leading the heart fail to deliver oxygen further metabolizing tissues. The terminology used for the heart failure is heart failure with reduced EF, heart failure with mildly impaired EF, and heart failure with preserved EF. The EF for the reduced heart failure is taken as less than 40%, and for the preserved it is taken as more than 50%, and we have the other terminology like new onset, transient, chronic, depending on the time course, and depending on the progression we have acute, stable and worsening, and based on location the left heart, right heart and the combined. The etiology of the heart failure may be endocardial, myocardial, valvular heart, valvular causes, and how functional status, that is high output state resulting in heart failure, that is anemia, thyrotoxicosis, AV fistulas, and the volume overload leading to heart failure, that is renal failure or post-operative fluid resuscitation, and arrhythmias, that is tachyarrhythmias and conduction disorders like AV blocks. The pathophysiology for the heart failure is the injury, hypertrophy, fibrosis and the electrophysiological changes which results in heart failure. The pathophysiology of heart failure, the ventricular remodeling is the crux for the heart failure which results in reduction of EF. The ventricular remodeling itself causes the electrical instability, and it also at the same time stimulates the neurohumoral response. The neurohumoral response are the renin-angiotensinogen aldosterone system, the sympathetic nervous system and the natriuretic peptide system. The marked red, the two things which is marked in red, that is renin-angiotensin aldosterone system and the sympathetic nervous system, affects negatively to the heart failure. The natriuretic peptide system acts positively, that is for the betterment of the heart failure. This is the renin and angiotensinogen aldosterone system where the angiotensinogen is released and it is acted upon by the renin which is released from the kidney, converted to angiotensin 1 by the action of ACE released from the lungs to the angiotensin 2. Angiotensin 2 acts on the glomerulosa. This is what we miss in most of the times, the natriuretic peptide system. This is very much useful for the decompensation, for the positive effects of the body for the patient to recover from the heart failure, that is the brain natriuretic peptide system. It has three natriuretic peptides. First is ANP, BNP, CNP. A is atrial natriuretic peptide. Second is the brain. Third one is the C-terminal natriuretic peptide. C, natriuretic peptide is released from the vascular epithelium, which helps in the vasodilatation. All the three acts upon the vascular epithelium. It causes vasodilatation. It inhibits the aldosterone. It also increases the GFR, and also it causes natriuresis. And this also acts upon the brain by decreasing the ADH, antidiuretic hormone, which thereby decreases the water intake. This is the positive and negative effects. The red has negative effects. One is the aldosterone system, that is increased on the right side. Lower column, that is the salt and water retention. Volume expansion is by renin-angiotensinogen system. And by sympathetic nervous system, it causes vasoconstriction and increased heart rate, which negatively on the heart. And the BNP system, that is brain natriuretic peptide system, it acts positively, causing natriuresis. Yes, these are the symptoms and signs of heart failure. Symptoms: shortness of breath, orthopnea, PND, exercise intolerance. And the signs specific, that is raised JVP, hepatojugular reflex, gallop rhythm, displaced apical impulse laterally, and murmurs. The comorbidities is a very much burden to the patient with the failing heart. The comorbidities itself cause decompensate the heart, and at the same time the drugs which use for the treatment of the gout or treatment of the COPD beta-2 agonist and the treatment of a renal dysfunction, and also the disease itself like anemia, which causes volume overload, sleep disturbance, obesity, by increasing oxidative stress, cause the heart failure. So the comorbidities itself cause heart failure, and the drugs used to treat comorbidities also worsen the heart failure. So it is important to note the comorbidities and treat the comorbidities in toto with the patient with heart failure along with treatment of heart failure. This is a brief diagnostic algorithm for the patient with suspected heart failure. First, assess the patient by clinical history, physical examination, then investigations, ECG. And we have to check for the natriuretic peptide, that is NT-proBNP. If it's more than 125 or BNP more than 35, then we go for sugar levels, HbA1c, lipids, and iron status. Yeah, here lies the questions. Where do we put the ARNIs, nephrolysin inhibitors and SGLT2 inhibitors, and where do we put the soluble guanylyl cyclase stimulator like vericiguat and riociguat, and what about the digoxin? Where should we fit the digoxin into our heart failure regimen? And when should we refer a patient for ICD, intracardiac defibrillator, or cardiac desynchronization therapy? Right, this is the big four. These drugs are to be used in the patient with ejection fraction less than 50% for all the cases, that is in reduced EF and minimally reduced EF. These are the big fours, that is the ARNIs, beta blockers, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. Right, this is based on the evidence and the decision making in the heart failure based on clinical trials, that is pioneer heart failure studies, which compared the sacubitril and valsartan with the endopril, which shows the broader use of ARNIs in hospitalized and de novo heart failure cases. Addition of SGLT2 inhibitors improves outcomes in broader spectrum of heart failure with or without diabetes. Victoria, this is a study which comprised a high-risk patient, further improves outcome. First is the big four, that is the AC inhibitors or ARBs or ARNIs, beta blockers, mineralocorticoid receptor antagonists, SGLT2 inhibitors. Then we'll assess the patient. What are the additional drugs which we go on increasing on the patient depending on the patient scenario. If the heart rate is more than 70 after using a beta blocker, we consider ivabradine. And if the patient is recently hospitalized with heart failure, we use vericiguat. The black patient who are resistant to ACR and ARBs because of absent or decreased renin in the, we use the hydralazine with isosorbate dinitrate. And the digoxin role comes here when the patient has an AF with persistent symptoms possible, titrate it with every 2 to 4 weeks to a maximum tolerated dose in a 3 to 6 months. Right. This is the ESC recommendations, that is the class 1 drugs the ARPs, loop diuretics, the role of the fusimide. Next, the Evabrad is class 2A. It should be used. And the soluble guanylate cyclase is 2B. It may be used if the patient is recently hospitalized for heart failure. And the hydrazine and isosorbide is used in the patient. And when do you go for the ICD? When the left ventricular ejection fraction is less than 30% and the QRS is less than 130 milliseconds, we go for the intracardiac defibrillator. And if the patient is in sinus rhythm and ejection fraction less than 35%, if the QRS duration is more than 130 milliseconds, we go for the cardiac resynchronization therapy, defibrillator or pacemaker. So here, where to use ICD and where to go for ICD and where to go less than 50%, we go with a H2S mitral valve repair. Right, these are the additional therapies, that is the patient with comorbidities, how to treat the patient with comorbidities. The patient with heart hypertension should be treated according to the guidelines of hypertension. Type 2 diabetes, we have to go with the SGLT2 inhibitors. And the patient with the cancer therapy, we have to go with the multidisciplinary approach. And the patient with atrial fibrillation, we have to go with anticoagulation. The patient with iron deficiency, we have to go with the iron replacement. And the patient with atrial fibrillation can be good. We have to go with the atrial fibrillation ablation. And with the obstructive sleep apnea, we have to go with the CPAP. If the patient is with the cancer with cardiotherapy, we can go with the ARBs, AC inhibitors and beta blockers. This is as a whole in total what I have explained just now. This is first the establishing the diagnosis, then the target dosing and reassessing, then treating the scenarios of the patients accordingly, then the patient progressing into advanced or refractory heart failure, how to go forward. First, the big four RNs, being on the QRS complex duration. If the patient is not responding, he is going into refractory heart failure. We have to go off heart failure with the preserved EF. Beta blockers are avoided. The same all drugs are included except the beta blockers. In the right ventricular failure, because we have a lot of that treating the right ventricular failure, I included this in my slide. How to go forward with the right ventricular failure, because we use only two drugs. One is the diuretics and the spironolactone, and the other one is phosphodiesterase inhibitor heart failure. The patient has cardiogenic shock. This is the mortality rate, that is 4 to 6% in hospitalization, and within 3 months of after discharge, there is 10 to 30% of death and 50% by the end of 5 years. This is the comprehensive treatment versus the comprehensive treatment versus conventional, where in the conventional AC inhibitors and beta blockers used, but in the comprehensive we use big four, which increases the event-free survival by 8.3 years and the overall survival by 6.3 years. Yeah, I want to stress upon here the orange and the green one, that is the undertreated and the end target dose. ARPs, the target dose 38.5% are only reached in the guided directed medical therapy 8.6, Evabrad 47.4 and beta blockers 12.1%. Recommendation, first titrate to the maximal tolerated doses, reassess the ejection fraction every 3 months. SGLT2 inhibitors are useful for decreasing the CV mortality with or without diabetes. For all eligible patients, start RB therapy, add Evabrad in otherwise indicated after beta blocker therapy, refer for ICD, should not be unduly delayed. In the future, there may be heart failure with only left ventricular ejection fraction of less than 50%. We expect new medical and device therapies with target on the newer medical therapies with heart failure spectrum, which means advanced heart failure and genetic cardiomyopathies. We have recently saw the patient who has underwent xenotransplantation with a pig, with the genetically modified pig. Xenotransplantation is the future and always will be. Thank you.
Okay.
said at that time only, he is the person who has introduced the rheumatology in the Exams Institute, not only in Exams Institute, in ESA Institute, and throughout the country, he is a big person.
No parliamentary vote, no soda vote, no issue. We have to make this as a negative dimension. And you can see how the particular goes. Normal joint, standard perforation without damage. And established motor arthritis damage. We can help very less in established motor arthritis. Earlier we can definitely make a lot. And what are the morbidity occurring? It is inflammation, it is duration, severity. And early intervention makes lot of difference. Now, what is bad in rheumatoid arthritis? Inflammation. Inflammation is bad and inflammation treatable. Duration inflammation and severity inflammation determines the joint damage. Now, in rheumatology, we have to use DMRT, corticosteroid, bile. These are the three domains we measure every time patient comes. Like a cardiologist and neurologist, the era of the biologists and new DMRT started. Now, not only drug, there is a paradigm shift in the approach of rheumatoid arthritis. What I am treating in the 90s, today totally different. And various reasons, she starts to the approach, step up strategy, step down strategy. The biologic comes in the treat to the target. Attacks the organ and like high disease activity, with high titer, earlier, again you can consider multiple. There are special situations justified to go for biologic as a targeted therapy. Now, nomenclature of the biologic include monoclonal antibodies. What are monoclonal antibodies? Infliximab, adalimumab, belimumab. Receptor constitution, fusion protein, capital like etanercept. And MO is a mirror India we are practicing also. Now, safety of the biologic is most important. Before indication, try to know the safety. The diverticulitis, liver function test, rule out latent tuberculosis, viral hepatitis, intensive lung disease, neurodegenerative disease. Phone for demyelination. So, which drug is going for the demyelination, which drug going to cause cytopenia, and which drug is likely to cause conjunctival cortical. We used to heard previously my colleague, if you give infusion in a diabetic dysfunction, you are going to precipitate conjunctival cortical. Now, this is an era of major drug, later part of 99. JAK inhibitor, biologic and complex therapy come in the play. Now, see again TNF inhibitors, they are alpha blockers, cytokine RER key route. And till date, 5 TNF blockers have been identified and we are practiced and approved by FDA and the control media also. They are infliximab, adalimumab, golimumab, etanercept, and also centrumab. They are available in Indian market also. Now, having available not enough. What is the evidence? Even the drug control permit, if there are no evidence, I don't want to prescribe. Now, what is the evidence? This is the trial, pre-med trial, first trial, I was a part of the trial, where we compared adalimumab plus mitral combination versus adalimumab and mitral three-arm study. It is clear adalimumab mitral individual, mitral also. Now, this is a influence markers of primary influence markers. Now, it's the best trial where again the etanercept combination with methotrexate is more effective in controlling the inflammation and also minimizing the damage. Now, safety concerns, most important to latent infection, increased incidence of TNF inhibitors. Presumed to the cost effect. All TNF blockers do it. Some are more, some are less. Screening for latent tuberculosis by Montauk test and interferon gamma say must. They are positive, divided for. Some thoracic society advises to give only 2 months, but immunology we want to give us 6 months or 9 months negative therapy and start TNF blockers. Now, British society upset they say only 2 months, but American college rheumatology says 6 to 9 months. Variants of the increase, especially lymphoma, leukemia. Congestive cardiac failure, I told you, pain blockers, and also demalnutrition. The patient may develop demelting encephalitis or dyskitis, like symptoms due to like multiple sclerosis picture involving spinal cord and brain structure. And ISC inhibitor, tocilizumab, phase 3, found very effective, it is approved, and it is superior drug in systemic cancer DRE. And tocilizumab in most monospore studies show it is very effective on par with adalimumab. And safety concern again, TB screening must calculate perforation, especially associated with diverticulitis, any clear blocker can cause. And dyslipidemia also is a concern for us. Our T-cell core stimulators like abatacept is also very effective in rheumatoid arthritis, in peritoneal damage, and also minimizing the inflammation. Again, safety concern, risk of pulmonary infection, and the latent tuberculosis is also very high. Riticum, one of the wonderful drugs, not for treatment of rheumatoid arthritis. Not only rheumatoid arthritis, SLE, vasculitis and malignancy. Very wonderful drug in the treatment of extraarticular malformations like ILD and vasculitis, neural multiple. Second again, hypogammaglobulinemia. Routinely, it is a guideline where routinely it is done, but sometimes we don't because hypogammaglobulinemia very rare. In persistent hypogammaglobulinemia, we give rituximab. Efficacy will not be there, but more side effects will be there. And leukoencephalopathy is one of the well-known complications, but we should be aware of it. Small amount of JAK inhibitors has come in the picture since the last couple of years in India. That different of daraxonrasib. But if you see, that been approved in 2012 by FDA, rheumatoid arthritis, 5 mg BD, 2016 11 mg, and 2017 18 19 daraxonrasib approved not only RA, it approved for psoriatic arthritis, ankylosing spondylosis, and ACLS. What are JAK inhibitors? So for them, highly selective JAK1 and JAK3 inhibitor is highly effective in rheumatoid arthritis, provided evidence provided multiple randomized controlled trials in comparison with DMRD and TNF failure and also predominant TNF failure patients. Because in the beginning we were giving TNF failure patients because cost was very high. Now cost has become very less. New guidelines we can use before biology. Daraxonrasib, say JAK1 and JAK2 inhibitor. It also very effective. But JAK1 and JAK3 inhibitor not only effective in rheumatoid arthritis, psoriatic arthritis, ankylosing spondylosis, other indications like Sjogren's syndrome, polymyositis, vasculitis is also more and more data coming by inhibiting JAK1 and JAK3. In RF-Becon, a build-up and evaluated efficacy in monotherapy and combination in methotrexate, Begin and beam showed benefit of severe to moderate RA compared to conventional DMRD in terms of methotrexate biological failure patients. Right? And in the just 2 or 3 years back, we are using this only when biological failure just because of the cost and the risk of hyperlipidemia. Now we are using before biologics. Now, what are the concern of this JAK inhibitor? The venous thromboembolism, increased cardiovascular mortality, increased malignancy. My friend, any immunology is more effective, also more side effects. So kindly keep a watch on side effects. Try to know contraindication more than the indication. If you don't handle this, hyperlipidemia, repeated administration biology can cause anti-drug antibodies. By combination of using with methotrexate and azathioprine, this problem significantly decreases.
More to the dais, and also present Vice Dean Dr. Y.S. Raju also to occupy the dais. And last but not
Mahal
Shortage of time and we are running behind the time even for the speakers. Maybe very few people on this dais are going to speak about the present day conference. With due apologies to all the seniors who have spoken years together across the nation also. So we have just honored them by calling them on the dais and all those things. Now I request Dr. Tirupati Rao, Organizing Secretary, to say a few words. He has made an excellent arrangements within a short notice. Kudos to him from state body and national body also, and very good arrangements much as possible. I request Dr. Tirupati Rao to say a few words regarding the efforts he has made here.
And off the dais. So thank you very much, sir, for giving us this opportunity. AP Telangana EC members. So thank you very much. So under the guidance of Dr. Venkatramana sir, Vapareddy sir, and all other my seniors, so Pratima madam, my principal madam. So we made this. So thank you one and all the. So in December, sir, not only physicians together as a IMA. It's a wonderful body, and we are together here always for any program in games and academics. So whatever may be the program. So together IMA we are doing so many programs, and especially today's chief guest Dr. B.N. Rao sir. So for your presence here, we are very much happy, sir. Sir is very much senior and guide to me in all the programs of our IMA Nizamabad. So thank you very much, sir. And thank you one and all for making this event a grand success. Our more physicians and doctors and Bodhar, Kamareddy, our Nizamabad, and my HOD, Dr. Srinivas sir, and my faculty, and especially my postgraduates. So they did a wonderful job of everything. And especially Nathaniel, so he made wonderful work for this program, and also especially hospitals, hospital Dr. Pratibha and Motila, and Sukhibawa Hospital, Dr. Bhaskar Reddy and Dr. Rajkumar Gaud. So thank you very much. And this one, Intas and Novanatis, Sunpharma, Sanso and Aristo Telvas and Sun Pharma. Thank you for your cooperation. So thank you one and all. So thank you.
Respected people on the dais, off the dais, I warm welcome to the midterm conference Nizamabad, hosted by Nizamabad chapter. First, let me thank our state body giving this opportunity to the Nizamabad chapter to host this midterm conference. ABN Nizamabad chapter, after successfully conducting third state conference in the year 2018, was ready to accept this conference in the short notice of 1 to 2 months. 1 to 2 months is a short time to conduct any state conference, especially in the districts. But we could do it. It's a teamwork led by all our seniors, and a special, relentless, hard and fantastic hard work done by our secretary, Dr. JTR. A new star has born today. And supported by Vikram Reddy, our treasurer, so with the full advice of our Dr. Bob Reddy Saab, Dr. Suresh Saab, Dr. Karnakar, Dr. Srihari, Dr. D.N. Swami, all the seniors have guided this conference in a big way. I thank them all. For this midterm conference, we have fantastic topics carved by our scientific chairperson, Dr. K. Ramesh Garu, and coordinated with our co-scientific chairperson, Dr. Pratima Raj Garu, in a big way. Though she has a fever and she has held up with so many activities. She has made her time to give her talk. Give her a big applause. The topics mainly are very useful for all the physicians and postgraduates, and it has covered all the guidelines. Guidelines are very important to the day-to-day practice. And many conferences, the topics are shared by speakers by different faculties. The beauty of this is that only except 3 topics, rest of them are all covered by our physicians, senior physicians, HODs from different parts of our state. So thank you very much, sir, for so much taking paid for the topics. Not only academics, the Nizamabad chapter has taken keen interest to host local famous persons to satisfy our taste buds in the buffet lunch. So I request one and all to enjoy academic and food feast and go back with sweet memories, and forgive us if there are small fallacies in our big work. Thank you very much for giving this opportunity.
Sir and Venkatarana sir, Tirupati Rao garu, Narasimhalu sir, and my co-superintendents Secretary Shekhar sir, Rajarao sir, and my principal Indira madam, and all the honorable people who are sitting off the stage. Very good morning to all of you. And Nizamabad is known for hospitality, and I should congratulate Venkatarana sir and Tirupati Rao. We could get something, and we could go out with some knowledge through when we go out of this hall. So I congratulate the scientific chairman also for taking the good topics, and I should thank all the people who are speaking, who are sharing, and who have attended, and especially
here we are all in Nizamabad, all the general medicine team. It is a big team we are having. Our superintendent, Dr. Pratibha Raj, she is a professor, and we are also having Dr. Tirupati Rao as a professor, and Dr. Srinivas professor. We are having 3 professors, and I am very proud to say our college is having 10 MD general medicine admissions per year. So the work has been done in general medicine. It is very good, and I hope all the dignitaries who have come all the way, senior and junior colleagues, they will enjoy the academic feast as well as Nizamabad Hospital. Thank you one and all.
And it's a short span of time. I think not even 2 months, 1.5 months. And it's a wonderful, nothing short of state conference. And thank you for your hospitality. And at this juncture, I congratulate the chairman, organizing secretary, and scientific chairman, and Bob Reddy and his team. And I welcome all of you and wish all of you will enjoy the academic feast. Thank you all.
On the dash, of the dash. Welcome to you all for CPD Nizamabad. So the hospitality they are showing, we are witnessing. So we formed the possible best topics which is used for the general practitioners and postgraduates. I feel you enjoy the topics. I congratulate my best compliments to Nizamabad APA team and Dr. Tirupati Rao garu. It took since 2-3 months and contacting and contact with Tirupati Rao garu. Really is a very hardworking person. My best compliments goes to Dr. Tirupati Rao. Thank you very much for giving this opportunity. Thank you.
Dignity on the day, of the day. First, I should compliment to the Venkatarana for excellent and team for excellent. Here, I don't take much time. I appeal you. The API life membership will decrease from 11,500 to 8,000, including THC. Kindly become member. The lot of advantage you become member. The professional academic circle improve. To overcome the monotonous life and update knowledge and so repeating better. Not only become member, kindly active participation, organizing CME conferences will help you and your team. Thank you.
Dignitaries on the dais, off the dais. It is a very good conference organized by the team Nizamabad, particularly Bap Reddy sir, Venkatraman sir and Tirupati Rao sir. And it is looking like a state conference. House is full. Though I think he has planned in different way without putting that exhibition outside. So everyone is inside and the topics are also so good, exciting. So you will have a wonderful academic feast and as well as the hospitality of the Nizamabad. Thank you very much. My time for the speech because I can talk for 1 to 2 hours over the association. Since 2014, after formation of Telangana, I was associated with founder secretary and as a founder secretary of ad hoc body, first term, second term, third term, chairman elect now, last chairman. So I just wanted to say thank you to the Nizamabad people who have organized a very wonderful session. Thank you very much for your hospitality and the organization. I just hand over the mic to Dr. V.M. Rao. So after I think 40 years I met him. We were close friends during our hostel days. So it so happened that I met him here and couple of friends also sitting in the audience. We were all together in the hostel Usmania. Thank you very much to the team Nizamabad. Hip hip hooray. Dr. V.M. Rao.
Chairman elect Dr. Ramesh Garu, Secretary Dr. Rajarao Garu, Dr. Anupama, Dr. Indira, all delegates on the dais, senior doctors, ladies and gentlemen. Let me first congratulate the advisory committee, Dr. Venkatraman and Dr. Rao for inviting me to the chief guest. I feel sorry, Dr. Bapa Reddy Garu, Chief Patron, who is popularly known as Bapana. I don't know why he was not called onto the dais. By protocol, he has to be on dais anyway. I feel it's a privilege to address the august gathering of the physicians. In my view, the physicians are the best among all the specialists, among all the doctors, For the reason that the physician is the one who deals with all specialties, all doctors in the body. And for that alone, and for that reason, I really esteem the physician a lot. See, the COVID has taught so many lessons, but the best lesson that we learned is how important is the updating the knowledge. Knowledge is a flow, it is a continuous process. So you have only two options, either you go with the flow or you become stagnant. No in between. Unfortunately, many people think that by being virtue of my post, I think that I am more of a politician, of course, but I am also a academician. I take lot of interest wherever there is a. In fact, I came here for two reasons. One is for the Dr. Tirupati Rao, who is a very dynamic, and then he has got lot of energy. He takes any job, he does it perfectly and to the best. One is this being the academic conference. The second is because of his persistent invitation and request. Thank you once again. Now, the COVID has taught a lot of lessons as to why we should become updated the knowledge. Now we know, after having exhausted all the physiology, pathology, and the medicine, now we know that, but when it was there, nobody knew. It was the world, actually there was a world went into shock. The very existence of the human life, the mankind on the earth was in a questionable whether we can survive or not. But somehow, we passed it off because of the doctors. When the prophet saints became helpless, mosques and temples became silent. It was the doctors who came in the form of the God that saved. Really salute to our medical fraternity. As of now, you are out and new. The state IMA gives a top priority for the academic sessions. During our Telangana State Conference held in November in Karinagar. We made Dr. Tirupathi as a scientific committee chairman and he has done a wonderful job. More than conference, the scientific committee, the CME was appreciated. Dr. Shailaja, I'm happy to see them, Dr. Navina. See, they worked so dedicatedly. Everybody said, of course, conference was good, but best of the best part of it, when I started asking what was the best part of the conference, they said the CME. Everybody listened rapidly. So, my point is that we are busy. Once you get it practice, in the beginning you will struggle yourself, dedicate your time and energy to build up the practice. Once you become busy, then you become busy with so many things. That's the reason I appeal and request that we should never ever miss the CME program, wherever it is. I learned so many new things when in the lecture given by Dr. Tirupathi and the other one, Dr. Kranti, the heart failure. See, all our non-minor fails. At that point, dialysis dysfunction starts. That is the point where you say that heart is failing. That is how we should actually think. See, what is the disease? The body has got so many compensatory mechanisms, so much resistance that we have immunity. It will try to protect it. When that fail, the symptoms of the disease manifest. Then we say that this person is sick, this person is suffering from so and so. This is how actually we should look it out. Being the rheumatologist, I take a lot of interest in immunology. See, when the immunology gets disturbed, it takes two pathways. If the cytokine is more produced as a TNF, it leads to malignancy. If the cytokines are IL-2, IL-4, IL-6 leads to autoimmune disease. I'm trying to make it short. IL-6 is the driving pro-inflammatory cytokine. What I mean to say is that we have to see now the physician, unfortunately in India, the physicians are facing a lot of, hell of the time. The patient directly goes to bypassing the physician, goes to specialist. For simple reasons like backache, something like that. So, I made a proposal during last time when we had National IMA conference that let us make appeal to the government, whether it is central or state, that see that the rule has come in such a way that patient cannot go to the specialist bypassing the physician. It will serve two purposes. One is, it will not be a burden economically on the patient, and from disease-wise, it will be justified. It's not an impossible task. Actually, that is the system run in USA. It's good for the patient, good for the medical fraternity. When coming to the IMA, first time the state IMA has constituted a committee called Public Care Community Services, in which we appeal the doctors, IMA members, to adopt the villages for a comprehensive health care. Our Karnataka has adopted maybe around 30 villages. Doctors have adopted 30 villages. So we made a protocol. The first one should be the physician, a gynecologist, a dermatologist, and orthopedist. These four are minimum for a camp. So, as Rama said, physician is a backbone for a hospital, corporate hospital, everywhere. I feel like actually I've been talking at length, but because of the time, I feel better short myself to this. Thank you once again. There is a proverb. Every rumor is a true, remains true until it is proved otherwise.
Data in phase 3 and phase 4 trial manner. Right nowadays, this artificial intelligence, you can integrate, you can remove the cancer cells, culture in the artificial media, incubate with these drugs and see the effect, as well as you can study the toxicity. So that is called as functional information drug response profile platform, cell co-culture with the drugs. So that is the future. And then not only that, so you can see in this example how this drug combination works. Without hundreds of patients' data, these drugs can come into clinical practice and transform the way we practice in the field of not just hematology but in the field of medicine. This is called as artificial intelligence based pharmacoscopy. So again, this is a cartoon. You can see a 5 MB hard drive, such heavy in 1956, and this is today's yottabyte chip, 10 raised to power 12 GB. Just you can hold it with your hand, and that the transformation we have done over last 50 to 60 years. And then I would like to say, what is medicine today? Precision medicine. This is the epitome of precision medicine, right? Race car, within 1.8 seconds, all 4 tires changed and the car is back on the race. Within 1.8 seconds. You can understand how much of a precision you require to do this task. And that is exactly where we are heading in the field of medicine, in the field of hematology and hemato-oncology. So again, I'll just highlight one case we had. This is a 65-year gentleman where we will not treat for any blood cancer because of the age and coma. But not just, AML, he has induction failure, so refractory blood cancer with these novel targeted tablets. We did chemotherapy, he went into remission, he was at the advanced age of 66 years, he was taken up for half-match transplant. Now he is 3 years post-transplant, completely cured and leading a normal life. 5-10 years back, we would not even thought of putting these patients on any treatment, we would have straight away sent the patient back home on palliation. So this is the, so this kind of blood cancers, advanced age is no more a curse, right? Switching gears further, this is my part 4. I'll quickly wrap up, sir. I had another 11 minutes. So, hematopoietic stem cell transplant, a unique procedure that is known to cure cancer, immune diseases, bone marrow failure, and various metabolic disorders. It has been existed over 65 years and has been done over more than 10 lakhs patients all over the world. So it is fascinating to understand these hematopoietic stem cells, which are rare cells in the bone marrow, but they are transplant. I'm sure many of you might be thinking it is a surgery just like kidney or liver transplant. It is not a surgery, it is a simple stem cell transfusion, just like platelet transfusion, but it comes with lot of intricacies, and that's why you need a dedicated bone marrow transplanter. Blood group matching is not essential. What is essential is gene matching, HLA gene matching. Donors, particularly Telugu donors, are scared to come forward for stem cell donation. They believe we are going to extract bone marrow as an organ from their body. It is wrong. We just collect two stem cells just like platelet on an apheresis machine, and donor can join back the job immediately. Most important for clinician, bone marrow transplant is the last step with dismal outcome. That's a myth. It's the only curative treatment with cure rate more than 80 to 90% across the spectrum. So with regard to bone marrow transplant, donor availability no more a concern. You can do equally successful bone marrow transplant with any donor, full match or half match, right? So this is called as haploid critical donor. So what is new? In half match transplant, newer technologies has come. Again, this is called as graft engineering, stem cell graft engineering. You selectively remove the bad cells, push back the good cells and succeed the bone marrow transplant on this machine, right? And this was a very nice editorial. Haplo is the new block in 2014 blood. And with regard to this technique was invented across the globe in 2015, and we had our first patient therapy and radiotherapy. He underwent this T-deplete or most advanced half-match transplant now. Almost 6 years post-transplant is completely cured, leading a normal life, and he is a software engineer in Bangalore. And that's the impact of these novel, newer techniques and treatments. So these are new various milestones we have. The first half-match transplant across Telugu states in 2015. The youngest bone marrow transplant 9 months. This is again a challenging case. World's first 2 brothers being transplanted with a German donor. India's first successful double half-match transplant.
the oldest 71 years, and another 67-year gentleman, a renowned physician from Latur, Maharashtra, at the advanced age of 67 years, underwent half-mass transplant for a deadly blood cancer AML from his cardiologist, sir. So these are all, the myths are like bone marrow transplant outcomes have improved significantly over last many years, 40s, 60s, and currently cure rates are 90%. So this is the picture which comes to our mind when we think of hematological disorders, blood cancer or bone marrow transplant. Hopeless, cruel, useless, which is a myth. This is most effective, curable in more than 90% of the cases. So again, the world is moving forward, not just bone marrow transplant. You can do something called as double transplant, solid organ transplant without the necessity of lifelong immunosuppression. So this is the future coming up in a big way, and these are the few cured patients. So coming to mesenchymal stem cell, just few words. I am going to conclude in another 5 minutes, sir. My time 25 minutes. So mesenchymal stem cells, promise of the future. At this point of time, it is not approved, but yes, these mesenchymal stem cells can differentiate into various organs. So particularly degenerative disorders like neurodegenerative disorders, orthopedic degenerative disorders, cardiac degenerative disorders, they are still in the experimental phase. They have a potential to cure by differentiating into these different, committed or finite cells. But as of now, I think with regard to degenerative joint diseases, a lot of publicity across our state. Like it helps in cartilage regeneration, decreasing joint inflammation and increase osteoid formation, thereby increasing the cure rate without the necessity of joint replacement surgery. And this is how it is done. But it is still in its rudimentary phase. It is not approved by any of the regulatory authorities across the globe like FDA, EMA or DGCA. So at this point of time, still this is an experimental approach. So just my last part 5, gene therapy. We might be hearing a lot about gene therapy. In a simplistic language, what is gene therapy? Your genes are defective, you are cutting the defective genes and sealing with the normal. And that is exactly gene therapy. So CRISPR-Cas9 technique, what happens when you insert the genes, the problem is the genes can proliferate indefinitely and can cause various cancer. That is called as insertional mutagenesis. With CRISPR-Cas9, it is like a kanchi which let the gene expand up to limited potential, and once the job is done, it cuts and stops the reaction. And this reaction was discovered by two eminent chemists in 2020, and who were like Emmanuel Carpenter and Jennifer Doudna, who were awarded Nobel for this remarkable discovery. So again, this is how CRISPR-Cas9 works. It let the gene expand up to a limit, and it doesn't let the gene proliferate exponentially, causing various toxicities. So again, the gene therapy has immense implications. Not just gene therapy, drug development, animal models, genetic variations, materials, food, fuel, everywhere it is going to come up in a big way. So future of medicine is very exciting. Already the cure rates are in the tunes of 80 to 90%, and these newer therapies hold the promise of improving the cure rate in hematological diseases, blood cancers beyond 90%. Right? So India is no more a financially backward country. India is now one of the world's 5th economy as per the recent survey, and the COVID vaccine is the epitome of our progress. In a vaccine which normally takes 10 to 15 years to develop, in a country like ours, we have successfully developed that vaccine in a span of 9 months. And our vaccination cover is more than 80%. That's the reason why, without the fear of third, fourth wave, without mask, we are comfortably sitting here, thanks to our R&D, our scientists and our all healthcare workers. So there are many challenges, but there are many breakthroughs and approvals which hold the promise of improving the cure rates across various disorders, not just hematological disorders in the field of medicine. The future is very exciting. So we need to change our approach to offer the best possible chance of cure, survival, success across these neglected blood disorders and blood cancers. right? And like the famous saying by Darwin, it is not the strongest of the species that survives, not the most intelligent one, but the one most responsive to change. Hematology was in its rudimentary stages in our Telangana state. Now it is much developed, and it's a teamwork. We have, it's been more than 11 years at Yeshua Hospital, so much good, and I had been, privileged to have more than 300 transplants with all your support and cooperation. I would like to take this opportunity to express my sincere gratitude, and as the famous saying, when gratitude becomes an essential foundation in our life, miracle starts to appear everywhere. So with that, again, like the famous saying, coming together is beginning, keeping together is progress, working together is success. All these success and success stories across hematology, hematological oncology, would not have been possible without your relentless support and collaborative work together. So with that, I will conclude. Thank you so much for your patient hearing. I can see at the end of this exhaustive, not so relevant talk, I can see so many faces. I expected this hall to be like this, but what I can see is most of you are awake, listening to me. Thank you so much. I will be happy to answer if there are any.
Really wonderful, Dr. Ganesh, to take hematology. I think excellent, really congratulations.
In young adults in post-COVID era, a clinician dogma by Dr. V. Chandrasekhar sir. To moderate this session, I would like to invite Dr. Sumalata ma'am, Assistant General Medicine, RIMS Adilabad, Dr. V. Suresh Kumar sir, Senior Physician, Dr. Santosh Chitmilla sir, MD Gayatri Hospital, Nizamabad, and Dr. K. Ravindra Reddy sir, MD General Medicine, DNB General Medicine, DNB Cardiology, Consultant.
The 15% of the population will have the bladder dysfunction, thoroughly investigate and worked upon. People above 60 years have 50% of the bladder symptoms. Most of the dysfunction are treatable. Even good history and clinical examination can lead to diagnosis. Very few patients require sophisticated investigations. So what is the definition of the neurogenic bladder? The neurogenic bladder refers to dysfunction of the urinary bladder due to disturbance of the central nervous system, thus involved in the control of the micturition. The bladder dysfunction is more common in neurological diseases. Very important thing is 98% of lifetime bladder is in storage phase. So coming to the anatomy of the bladder, it is a very simple structure, intrapelvic structure. Males and females, the structural anatomy is different. Anteriorly it is the female's uterus, posteriorly is spinal cord and rectum. And what are the components of the bladder? So it is in empty bladder is in pear shape, in bladder in full it is oval shape. The components of the bladder are body of the bladder, neck, trigone, internal uterine sphincter, external uterine sphincter. So coming to the body of the bladder, it is made up of the involuntary muscle, that is a retrocessor muscle, and the trigone of the bladder is also made of retrocessor muscle, involuntary control, autonomic nervous system. And the neck of the bladder is usually we have internal uterine sphincter. It is made of retrocessor muscle. Then external mitral sphincter is a skeletal muscle that is voluntary muscle under control of the central nervous system, that is supraneural controls. It is initiation and inhibition of the bladder is controlled by this external urethral sphincter through the central nervous system, the cerebral cortex, paracentral lobule in the medial eminence of the frontal inferior gyrus. So these are the capacities of the bladder. Normal bladder capacity 300 to 600, and the sensator of the bladder filling is 100 to 200 cc, and the first hard to void urine, the 300 to 400 cc, usually 600 to 800, and maximum anatomical bladder capacity is 800 to 1000 cc. So these are the capacities of the bladder. So this is a little bit important slide. Receptors of the bladder. So there is a sympathetic nervous system. There is a sympathetic nerves, parasympathetic nerves. There is a preganglionic fibers, postganglionic fibers, and preganglionic neurons of the sympathetic nervous system leave the central nervous system for the bladder at the level of the spinal cord, that is T11, T12, L1, L2 and L3. And postganglionic neurons, they derive from the posterior hypothalamus and they leave the central nervous system. These neurons at the level of S2, S3 spinal segments, intermediolateral arc of the spinal cord. So these have preganglionic fibers or the postganglionic fibers act on. So the bladder wall contains M3 receptors and the nicotinic receptors, that is M3 receptors, the muscarinic receptors for the parasympathetic postganglionic fibers. The stimulation of the M3 receptors, the postganglionic muscarinic receptors in the bladder wall is causes contraction of the bladder, and alpha-1 receptors in the intraurethral sphincter, that is sympathetic receptor, the postganglionic sympathetic receptor causes relaxation of the bladder. And also the nicotinic preganglionic receptors of the parasympathetic nervous system, it causes inhibition or receptors, they control the bladder. Postcentral gyrus, that is sensory impulses, pass to the precentral gyrus, the motor area. From the motor area, paracentral lobule and the incisura, they pass it through the parental nerve. This is also very important stage or the innervation of the bladder. Sympathetic supply and parasympathetic supply. Bladder fibers of the sympathetic supply, the preganglionic fibers, they arise from the T11, T12, L1, L2 intermediolateral horn cells of these spinal segments. Ganglion, the postganglionic fibers arises. This is called as the hypogastric nerve. So on stimulation of the hypogastric nerve, it causes relaxation of the bladder and the contraction of the internal urethral sphincter. The sympathetic nervous system called as filling nerve and continence of the urine. Sympathetic nervous system involved in the filling of the bladder and it maintains the continence of the urine in the filling phase. And the parasympathetic supply, it arises from the S2, S3, S4 intermediolateral horn cells. The preganglionic fibers, they descend down, they lay in the inferior hypogastric ganglion as a pelvic nerve. The postganglionic fibers, they form pelvic nerve. They supply, they innervate M3 receptor in the bladder wall. This causes contraction of the bladder and the relaxation of the internal urethral sphincter. So this parasympathetic nervous system called as nerve of urination. And the pural nerve arises from the paracentral lobule in the cerebral cortex. They descend through the internal capsule, midbrain, pons and medulla oblongata. Lastly, they land at anterior horn cells of the S2, S3, S4 spinal segment. These anterior horn cells of the S2, S3, S4 spinal segments, they form the pudendal nerve. It is a voluntary nerve. It causes voluntary micturition, voluntary initiation of the micturition, and voluntary inhibition of the micturition. That is pudendal nerve. It is under voluntary control. This is the innervation of the bladder. This is a little bit confusing. So parasympathetic nerve supply, already I mentioned few things. That is also called as the nervi irrigatis, also pelvic nerve. So S3, S4 spinal segments are intermedial lateral zone, preganglion, parasacral, pelvic sacral nerve, synapse in the inferior hypogastric ganglia, and postganglion cholinergic fibers of the acetylcholine muscarinic receptors M2, M3 in the bladder wall, causing contraction which causes motor to the detrusor. The parasympathetic nerve, it is a visceromotor and a viscerosensory to the bladder. Visceromotor fiber, it causes contraction of the bladder, relaxation of the internal ventricular sphincter, and afferent fiber of the parasympathetic nervous system. They carry the bladder sensation or pressure sensation through the bladder, carried to the spinal cord. From the spinal cord, efferent fibers of the parasympathetic nervous system through the nervi irrigates and pelvic nerve is causes contraction of the bladder. So parasympathetic nervous system having the afferent fibers, that is viscerum sensory, and efferent fiber, that is viscerum motor, that is pelvic nerve. This is the nerve of urination. The role of the internal urethral sphincter in the micturition reflex is very minimal. It causes the role of the internal urethral sphincter in the micturition is it prevents the semen ejaculation in the bladder. So that is the role of internal urethral sphincter. The sympathetic nerve supply, that is the hypogastric nerve, already I mentioned. They arise from the intermediate lateral of the T11, T12, L1 and L2. These are bladder fibers, sympathetic fibers. Preganglion fiber, the synapse is the inferior hypogastric ganglion, postganglion fiber, the hypogastric nerve. It maintains the continence of the urine during milling phase, and beta adrenergic receptors in the bladder wall cause the relaxation of the detrusor muscle and the trigone. Alpha receptors in the internal urethral sphincter cause the contraction of the internal urethral sphincter, that is storage of the urine, and also causes contraction of the proximal urethra. Painful sensations of the bladder distension. It is conveyed to the spinal cord, to the posterior ramus, dorsal rami, to the posterior dorsal column. Through the dorsal column, it enters into the posterior central cortex, that is sensory cortex. Through the sensory cortex, impulses pass to the motor cortex. In the motor, they analyze whether bladder is full or not, the atmosphere is suitable for the urination, time and place. If the atmosphere is suitable and the patient is educated for the urination, and the signals from the upper motor neuron, that the paracentral lobule and incisura and the other centers in the brain, it causes stimulation to the Pontine micturition center, the switch off system center, and there is a immediately reflexes are gone. There is a fifth stage reflex and causes urination. It is motor to the external urethral sphincter, and also it is motor to the pelvic muscles. It is also mixed nerve. It carries the nausea sensation, painful sensation, pressure and temperature carried to the spinal, anterior and lateral spinal thalamic tract. It carries to the posterior central gyrus, and the inflammation passes to the motor center. So what are the other neural controls of the micturition process? So already I mentioned the cerebral center, hyoid center, the upper motor neuron center. It controls the bladder or the micturition at the level of Pontine, inhibit the Pontine center, Pontine micturition center. The second is Pontine micturition center. It switches between the filling phase and voiding phase, and the spinal cord, the ascending fibers, descending fibers. Descending fibers are corticospinal fibers, reticulospinal fibers, parasympathetic sympathetic fibers. Ascending fibers are usually the lateral and anterior spinothalamic tract fiber and posterior column fibers. This is the second center, and third center is that is spinal sacral center, primitive center, that is lower motor neuron center, that is for sympathetic afferent and efferent and parasympathetic afferent and efferent for the bladder center, that is suprapontine center, that is upper motor neuron center for the micturition reflex. The location is for paracentral lobule in the medial aspect of the frontoparietal cortex. Other areas are for micturition controlling cingulate cortex, periapical cortex and insular cortex. The function is, it always inhibit the pontine micturition center, always keep the pontine micturition center in switch off mode. It is for voluntary control and inhibition of the micturition until it is socially acceptable environment. And dysfunction of this cortical micturition center, it causes loss of social control of bladder, that is called as disinhibition bladder, cortical bladder or infantile bladder. In the area of PPR, there are two areas, L region and M region. L region for the sympathetic and corticospinal fiber, that is the storage, and the function is continence of the urine, storage and contraction of the rectal sphincter and distension of the bladder. But through the sympathetic and corticospinal fibers, it acts on the sacral center, and the other region is M region, dorsomedial in the pons. It is reticulospinal tract. Through this tract, sympathetic fibers and the parasympathetic fiber, they control the bladder involuntarily. The function is the micturition center. Stimulation results in the contraction of the retrosor, decrease the infiltration, relaxation of brain fluid muscles, and causes urination. T12, L1, L2 intermediate lateral hump, and the parasympathetic fiber descend through the involuntary control of the bladder through these areas and major the intermediate lateral hump, S2, S3 and S4, and the spinal corticospinal tract and the voluntary control from the pyramidal set, better cells in the paracentral lobule, the cerebral cortex, and then they mediate the anterior house cell of the S2, S3, S4 spinal segments in the spinal cord. The ascending tracts are lateral spinal tract and the posterior column and the sacral lymph center. So already I mentioned. So this is the sacral cord, S2, S3, S4, that is pelvic pancreatic nerve, somatic nerve.
ఈరోజు మన నిజామాబాద్లో మొత్తం రాష్ట్ర స్థాయి ఫిజిషియన్ సదస్సులో భాగంగా మన జిల్లాలో ఈ వంశీ ఇంటర్నేషనల్ హోటల్లో నిర్వహించడం జరిగింది. దీని గురించి దాదాపుగా ఒక 300 మంది ఫిజిషియన్లు మొత్తం రాష్ట్ర వ్యాప్తంగా హైదరాబాద్, అదేవిధంగా వరంగల్, నిజామాబాద్, కరీంనగర్, అదేవిధంగా ఖమ్మం, నల్గొండ ఇట్లాంటి అన్ని ఉమ్మడి జిల్లాల నుంచి ఈరోజు చాలా పెద్ద ఎత్తున రావడం జరిగింది. ఈరోజు మొత్తము ప్రపంచంలోనే అత్యాధునికమైనటువంటి ట్రీట్మెంట్ ఇటు క్యాన్సర్ విషయంలో కావచ్చు, ఇటు డెంగ్యూ జ్వరం కానీ, ఇతరత డయాబెటీస్, అదేవిధంగా అంటే షుగరు, బీపీ ఇట్లాంటి వ్యాధులు కొత్త కొత్త పద్ధతులు ఏమొచ్చాయి, కొత్త ట్రీట్మెంట్ ఏమొచ్చాయి, దీనిపైన పూర్తి స్థాయిలో సదస్సులో ఈరోజు చర్చించడం జరుగుతుంది. ఈ సదస్సుకు ముఖ్య అతిథిగా మా డాక్టర్ బిఎన్ రావు గారు రాష్ట్ర స్థాయి ఐఎంఏ ప్రెసిడెంట్ వారు రావడం జరిగింది. అదేవిధంగా మా ఏపీఐ చైర్మన్ రాష్ట్ర స్థాయి తను డాక్టర్ నాగేందర్ సార్, అదేవిధంగా గాంధీ సూపరింటెండెంట్ డాక్టర్ రాజారావు సార్, అదేవిధంగా వరంగల్ ఎంజిఎం సూపరింటెండెంట్ డాక్టర్ చంద్రశేఖర్ సార్, అదేవిధంగా మన జిల్లా ఆసుపత్రి సూపరింటెండెంట్ డాక్టర్ ప్రతిమా మేడం, మన ప్రిన్సిపాల్ ఇందిరా మేడం గారు, అదేవిధంగా డాక్టర్ జి నరసింహులు సార్, మన రుమటాలజీలోనే మన పితామహ అంటారు మన తెలంగాణ రాష్ట్రానికి. ఇట్లా సీనియర్ డాక్టర్లు ఎందరో మన దగ్గర రావడం జరిగింది. డాక్టర్ గండయ్య గారు, ఇలా ఇంత పెద్ద పెద్ద సీనియర్లు, ఇంకా ఎంతోమంది వక్తలు, డాక్టర్ రమేష్ గారు ఇట్లా వచ్చేసేసి ఎంతో చక్కగా ఈ సదస్సు అనేది నిర్వహించడం జరుగుతుందండి. ఈ సదస్సులో ఇటు పీజీ విద్యార్థులు, అదేవిధంగా ఆల్రెడీ ప్రాక్టీస్ చేస్తున్న డాక్టర్లు అందరూ రావడం వల్ల వాళ్ళకు అత్యాధునిక పద్ధతులతో ఇంకా మన దగ్గరకు వచ్చే పేషెంట్లకి ఇంకెంత మంచి చికిత్స ఇవ్వచ్చు, ఇలా అంటే తక్కువ ఖర్చుతో మంచి నాణ్యమైన ట్రీట్మెంట్ ఎలా ఇవ్వాలనేది ఈరోజు పూర్తిగా చర్చించడం అనేది జరిగింది. ఈ కార్యక్రమానికి విచ్చేసిన ప్రతి ఒక్కరికి పేరు పేరున ధన్యవాదాలు. అదేవిధంగా ఈ కార్యక్రమానికి నాతో పాటు ఉండి నాకు సహకరించిన మా డాక్టర్ వెంకటరమణ గారికి, డాక్టర్ విక్రమ్ రెడ్డి గారికి, అదేవిధంగా డాక్టర్ బాపురెడ్డి సార్కు, మా పీజీ విద్యార్థులందరికీ, మా ఇతరత్ర తోటి సహోదర ఫిజిషియన్లకు, ఇతర డాక్టర్లందరికీ, మా సిబ్బంది అందరికీ కూడా పేరు పేరున ధన్యవాదాలు. అదేవిధంగా మీడియా మిత్రులందరూ కూడా పేరు పేరున ధన్యవాదాలు తెలియజేస్తున్నాను.